Yeah, the idea of preventive therapy is to kind of take an approach which has been very successful in cardiology to actually not wait for disease to develop, but to identify high-risk individuals and lower their risk. So for example, if you went to your cardiologist and you were told you've got high blood pressure, come back in a year, we'll see you had a heart attack, you wouldn't be too pleased. So high blood pressure, high cholesterol levels are now treated more as diseases, not simply as risk factors, and we have effective treatments which actually lower those and have a major impact on cardiovascular disease. So the idea is to bring that concept into cancer a bit more. And there really are two approaches. One is sort of agents that can be used really quite widely across the general population. For example, aspirin, which we think is something that looks very, very exciting for cancer prevention. And other areas where the toxicity is sufficiently high that you want to target high-risk individuals. So for example, in breast cancer, we can identify women at much higher risk of breast cancer than the general population and offer them hormonal treatment like tamoxifen or aromatase inhibitors, which can reduce their risk by 50% or more. We like to think that these are not really patients, but they're really members of the general population with risk factors. They're not really patients, they're not really getting active, serious treatments. The challenge is how best to proceed with this. It's clear that general practitioners have a major role to play, and we have a major role to actually make them much more aware of what the options are, what the benefits are, what the side effects are, and who would benefit from preventive therapy. One of the things we're exploring in breast cancer in particular is we think that one of the great places to actually explore these options is during the screening invitation. So women come for a mammogram, and when they come for their first mammogram between the ages of 45 and 50, we would very much like to see a discussion about not only do you have breast cancer now, but what your risk is and what you might be able to do to prevent it. So for some women it'll just be maybe take a little more physical exercise. For a few at a very, very high risk level, they might want to consider surgical procedures. But for maybe 5 to 10% of the population, their risk is high enough that they might want to consider preventive therapy, but not high enough to consider surgical procedures. Chemoprevention for breast cancer has been evaluated quite thoroughly in 4 major clinical trials. In fact, 4 for tamoxifen. The Royal Marsden study, which began in 1986, followed by 3 national studies, our own IBIS-1 study, an Italian study, and an American study, all which began in 1992. We now have 20-year follow-up on our own IBIS study and have been able to show convincingly that taking tamoxifen for 5 years prevents breast cancer for up to 20 years and possibly longer, continuing year on and year off for 20 years now. So we have very good evidence from clinical trials there. More recently, we've been looking at the aromatase inhibitors, and there are 2 large trials, each of about 4,000 patients, showing very clearly that you get a larger effect. This is only for postmenopausal women, not premenopausal women like tamoxifen can be used for. But we get between a 50 and 60% reduction in breast cancer with aromatase inhibitors. One of the most exciting things in cancer prevention is data coming from trials that were either done in the general population or in individuals with risk factors for heart disease, looking at low-dose aspirin, or indeed standard aspirin. And those results have only come to light more recently because, in fact, the effects of aspirin on cancer don't show up for about 5 years. But after 5 years, we're seeing very dramatic reductions in colorectal cancer, stomach cancer, and esophageal cancer, all reduced by about 1/3, with small benefits of about 10% for breast cancer, prostate cancer, and lung cancer. So if one were to say, I want to prevent cancer, the single most important thing to do is to not smoke. But numerically, the second most important thing you could do is to take a low-dose aspirin for between 5 and 10 years, between the ages of 50 and 70. So we're very keen that this approach is much more widely used now. I'm very much a believer that physical activity is very important for health, including cancer. We need to do the randomized studies to really show that interventions that increase physical activity will actually reduce recurrence rates. There's a lot of observational data that suggests this is true, but very important, I think, to do this in a proper controlled randomized trial. And we've looked at this. Probably we would begin with women with cancer, breast cancer, where there is quite good evidence that in fact physical activity will reduce recurrence rates. Same, I think, for men with prostate cancer. So that's a good place to start and is less daunting than trying to do a prevention trial, which would require many more people and we require a longer time to get an answer. But I think it's very important. As for diet, I think we still don't know a lot about what the important dietary factors are. We know that weight control is very important, and we've had a recent spate of information about red meat and processed meats, which I think maybe is a little bit of a distraction from real prevention. There is an effect there, but it's small and it's a little bit been overstated. This is probably secondary to physical activity in my view.